Good afternoon, folks. I've got discussion A for you. Now we're discussing rethinking treating diabetes, hypertension in frail older adults. Okay, I'm going to do a presentation for you today about that. Here we go. The article emphasizes a critical paradox in geriatric care while managing chronic conditions like diabetes and hypertension can improve longevity and quality of life. Overly aggressive treatment in frail older adults often backfires. Instead of preventing complications, strict regimens can trigger dangerous episodes of low blood sugar, hypopolyglycemia, or low blood pressure, hypotension, leading to emergency visits, hospitalizations, disability, or even death. These harms are not inevitable. They are preventable, but they stem from well-intentioned care that fails to account for the realities of aging bodies. Why overtreatment is harmful. Rigid targets versus fragile physiological or physiologically standard treatment guidelines often aim to tight control of blood sugar and blood pressure. But in frail older adults whose bodies may not tolerate fluctuations well, these targets can destabilize rather than protect. Medication risks. Sliding scale insulin aggressive antihypertensives can cause sudden drops in glucose or blood pressure. For someone already vulnerable, this can mean falls, confusion, or organ damage. Mismatch with life expectancy. Pursuing long-term prevention goals like reducing cardiovascular risk decades ahead may not make sense for patients with limited life expectancy. The immediate risks of overtreatment outweigh the distinct benefits. What experts recommend: individualized care. Geriatric specialists stress tailoring treatment to patients' age, health status, and comorbidities. For example, the American Diabetes Association recommends more relaxed HbA1c targets for older adults with poor health or multiple conditions, avoiding risky practices, updated long-term guidelines, caution against sliding scale insulin overly strict diets and medications that heighten hypoglycemia risk. Holistic focus. Instead of chasing numbers, clinicians should prioritize comfort, safety, and functional independence. System and policy changes urged. Joseph Oslander and Michael Wiseman argue that the problem isn't just clinical, it's systematic. Currently, quality measures often reward hitting numeric targets rather than preventing harm. They call for redesigned accountability systems that encourage clinicians to avoid overtreatment, quality measures that reward safety, evidence-based, personalized care rather than rigid adherence to targets, support for providers to make good decisions without fear of being penalized for not meeting strict benchmarkers, practical implications for clinicians and caregivers. Assess overall health and life expectancy before setting treatment goals. Favor similar regimens that reduce risk of hyperglycemia or hypertension. Watch for warning signs, dizziness, confusion, weakness that may signal overtreatment. Engage caregivers and family members or families in discussions about realistic goals and priorities. Advocate for systematic change so that safety and personalization are valued as much as numerical outcomes. Key takeaways: managing diabetes and hypertension in frail older adults is not about pushing numbers lower at all costs. It's about balance, recognizing that aggressive treatment can cause more harm than good, and that individualized, cautious approaches better serve vulnerable patients by shifting both clinical practice and policy toward personalization and harm reduction. Healthcare systems can avoid or can reduce avoidable emergencies and ensure care truly supports dignity, safety, and quality of life. Okay, guys, that's your A for this afternoon. I will be back on shortly with B and C. So for now, Gator Wellness, take care, folks.